everybody. Thought we'd take a sec while Dr. O was up with one of his normal monthly visits to talk about a new, not new, but some information you probably heard from your officers after our last officers meeting regarding when should we maybe consider using a helicopter a little bit more frequently than we have probably in the past? When should we consider going up to one of the level 2 trauma centers up north? Or when is it that Davis is an appropriate destination for our trauma patients? The topic came up recently after a couple more notable incidents that we had. And after that, I kind of reached out to Dr. O and I said, you know, what are your thoughts on our practice now versus the way that we were maybe years ago? As we've evolved as a department and as a community, should we kind of re-examine where we're at with this? And so he spent some time kind of thinking about our approach to things. I talked with the chiefs, Chief Adams and, or excuse me, Chief Mon and Chief Ward. We had lunch with Chief Adams today about kind of our approach. And I think we've settled into a sweet spot of kind of a best practice moving forward. So we just wanted to spend a few minutes. So Mark, kind of maybe where we're at and what started some of this and kind of your thoughts.
Yes, so as you know, we had a couple challenging cases that came up during the month of August. Both of these were level 1 type trauma patients. One was a multiple gunshot wound, one was a pediatric patient. And unfortunately, both of them had less than desirable long-term outcomes. And I don't think we can pin that on any one particular reason. But it caused us, it was brought to my attention to kind of relook at, as an agency, what is our role and what can we do to maximize the best outcome for the patients in the city of Layton who are suffering with critical trauma injuries. I've always been a very big proponent of getting the patient to definitive care. And I think over the years, I've also been one who has put a big emphasis on minimizing scene time, especially in trauma patients, trying to keep that less than 10 minutes. To the point that I've also given you a skill set that I feel mimics that of a helicopter, such that we don't need to be calling a helicopter in every case of trauma. We have the skills to do a lot of the care they do. We don't carry blood, but most other interventions we have, and we have the ability to get them to definitive care at McKay-Dee, which is our level 2 trauma center up here. I want to make a little differentiation between trauma centers. So McKay is a level 2, Davis Hospital is a level 3, and Layton Hospital is also a level 3. And then we have the university, we have primary, and we have Intermountain, who are all level 1 centers. And there's quite a big difference when it comes to the capabilities of a level 1 center or a level 2 center versus a level 3 or 4. And there's quite a big gap between 1 and 2 and 3 in terms of what the in-hospital care and surgical care consists of. In both of these patients we had, whether our hope was to rendezvous with a helicopter at the hospital, I think we realized that in both these scenarios, the patient had a need for critical advanced care. And we minimized scene time. We got them rapidly, in both cases, to Davis Hospital, where they were brought into the ER for stabilizing care, but additional care beyond that. One of the patients actually went to the surgical suite. And, you know, both patients had critical injuries. Both may have succumbed to their injuries no matter where they went. But when we're dealing with cases of critical trauma, we have guidelines that we can turn to that help guide us in the care. And one of the things I've sent to the chiefs is the national guideline for the field triage of injured patients, which categorizes patients either into a red status or a yellow status. And this guideline gives us recommendations that if you fall in a red status, that these are the patients that really benefit from the highest level of trauma care. In most cases, that's a level 1, but level 2 has capabilities that could meet this in scenarios as well. And it's in those cases where we really want to focus on getting that patient to that definitive level 1, level 2 trauma care in the most expeditious way possible. We've taken the approach in the past, and I was with Jason many years ago on a critical gunshot wound where we rendezvoused with a helicopter at Davis Hospital. We arrived in the parking lot, went right on the helicopter. Jason and I have discussed this, and I don't know if that's always the best approach. I think, and I know, we can safely land helicopters on scene as well as, if not maybe even a safer scenario than rendezvousing with a helicopter on the helipad at the parking lot at the hospital. So what I would like to see is, if we're considering the need for helicopter evacuation to get that patient to a definitive level 1 or level 2 center, that we activate that helicopter on scene. Again, there are caveats. If you're right next door to the hospital, we had a case within the last week where the injuries sustained were right next to the hospital on Antelope Drive, then by all means head over to the hospital. There may be weather considerations in this. There may be delayed activation of the helicopter, either for availability or weather issues. So it's not a one, plan fits all, but I would prefer us to move toward a model where we recognize the need for level 1 or level 2 trauma care, exercise the use of helicopter emergency service activation, and use that as a scene flight. Not to take hospitals like Davis out of the loop, but realizing these patients benefit more from a level 1 or a level 2 care, especially when it comes to pediatric patients. I mean, we really don't have any hospitals up here that can approach the level of care that Primary Children's can for a critical pediatric patient. That's really the only destination I think we should be considering for those patients. And so I would say in those cases, seeing helicopter activation is probably the way we ought to be going again, unless there are some other extenuating circumstances. But those are not patients that are going to be staying at Davis Hospital, at Layton Hospital, or even at McKay-Dee. So why not get them to definitive care while you're still in that golden hour of trauma care? When it comes to adults, we have more options. If we're close to McKay-Dee Level 2 Center, by all means, head to that facility. If we're closer to Davis and this patient falls into that red status, then maybe that's an indication to activate a helicopter and do a scene response. I don't mean to shake things up. I'm still sticking with what I've said before. We want to minimize scene time on trauma care. But what I'm looking to move away from is this thought of maybe trying to rendezvous with a helicopter on the helipad at Davis Hospital. If you have a need for a helicopter, get it to the scene, and as long as that can be done in an expeditious fashion. In terms of recognizing the patients that are going to most qualify from a helicopter evacuation and transport to a level 1 or 2, well, that's where we go to our guidelines and use our guidelines to help us with that decision making. Red criteria for the national guideline for the field triage of injured patients identifies things like penetrating injury to the neck, trunk, or head, or proximal extremities, skull injury, skull deformity, spinal injury with neurodeficits, flail chest, chest wall instability, situations where you're dealing with respiratory failure, obvious pelvic fracture, multiple proximal long bone injuries, pulseless extremities, and I'm not just saying, shoulder dislocation where you might have thready pulses, but somebody who truly has no pulses, somebody who's required a tourniquet on a proximal extremity, or somebody who's got a significant amputation that's above the wrist or above the ankle. So those are injury patterns that would benefit from the highest level of trauma care. And then we also have vital signs, and we'll put this out there as a resource that people can refer to. But if the patient's heart rate is greater than their blood pressure in an adult category, that's generally someone who is compromised and would benefit from the highest level of trauma care. So,
Yeah, so a couple of really important things that you brought up. First of all, Chief Mons asked me to put together a new policy. Included in this are going to be the guidelines that Dr. O shared with us as the Chiefs group, so that you can refer to those. in your decision making and kind of discussing this around the kitchen table a little bit. What about that gestalt though? Like we just get on scene, maybe we're looking at iSpire or details on the computer, and we're like, this looks bad. And we put a helicopter in the air or whatever, just based on some information. Remember, we can always cancel a helicopter if that ends up being the case and that person's not as badly injured as we thought. And I think it's sometimes okay to over triage. But like Mark, I just want to reiterate kind of what Mark shared. Like, we kind of get a vibe on those patients that we know need to be in Salt Lake or need to be at a level 2 trauma center. And our folks, and by the way, the folks at the hospital have really invested in these patients recently, thinking and hoping that they were doing the right thing. And I don't want to take anything away from what anybody's done, but the way that the system's evolved, we're finding more frequently that those patients that we thought we were going to have a quick turn in the parking lot at the helipad are ending up going inside and spending too long. Couple points to bring up too. I spoke with both Brian Law and Jolynn, specifically at Davis Hospital. They totally understand our point of view, and they're supportive, so they understand that. Reiterate too, there are certainly going to be occasions where you're going to end up going to Davis still, and you should, and we will always support that. One of those that you didn't mention is if somebody's in cardiac arrest or peri-arrest as a trauma patient, like you legitimately think you're going to be doing CPR on this person soon, by all means go to the hospital. And if you just in your heart, or you just are convinced that you should go in that hospital, then by all means you should go in that hospital. But you know, one of the captains said to me after their incident recently, they said, you know, I hate going lights and sirens to the hospital because we don't do really good care in the back of the ambulance because we're jostling around and doing everything. And I just feel like we'd be better if we stayed and did what we did. And that's exactly what we want you to do. So stay and do good airway practices, stay and do good bleeding control, get IV access, manage that patient the way that you've done for years and done very, very well at. And then help support the flight team when they land on scene to do whatever interventions they need to do, helping you with an RSI or a more critical airway intervention, injuries to the chest, they may do some things that we can't do, and then get that patient gone. And so I think this is a good approach. It's something that we've been deliberate and thoughtful about, and so I hope as incident commanders, those of you that are medics on the rigs, when you are in one of those circumstances, I want you to feel empowered to call for that flight team. A couple caveats about the flight team. If you call and for whatever reason this helicopter isn't at Davis Hospital and you hear, well, they're coming from Salt Lake or they're coming from Tooele or Park City or wherever, and if you don't feel that investment of time is better spent than going by ground to the level 2 centers up in Weber County, or frankly, even maybe to Salt Lake, by all means do that. Don't, just because we've said consider using helicopters more frequently, feel like you're locked into that decision. Because there's always going to be occasions, no matter what, those of us that fly or otherwise, that we wouldn't recommend it. So again, this is something that we want for those of you, again, this is infrequent. These are not a lot of our call volume. I don't think it's appreciably going to change things much for us, you know, year to year. But we wanted you to know that as chiefs, as our medical director, and even the medical community, like I said, we've spoken with the hospital, that that in the circumstances similar to what we've had or otherwise, feel empowered to call for a helicopter. Let's utilize our law enforcement partners. Like Mark said, we can do it very safely. I think the evolution of this has become, well, it's safer for us to go over and do a rendezvous at the helipad. The original notion was actually, because of how close we are to the helicopter, we can transport there while they're getting out to and getting spooled up and narrow that interval that the patient's getting into the helicopter. And while at face value that seems like a great idea, it's getting interrupted periodically, and so that's what we're trying to maybe circumvent by bringing the helicopter to the scene. But we can land anywhere in town. There are absolutely safe LZs in very close proximity to everywhere that you are in town. So it's not a safety issue. Utilize our law enforcement partners. Chief Ward would be thrilled if you had another engine come if you feel the need to help secure our LZ. Do it as safely as you can. Do it as early as you can so that that interval between when we get a launch request and when they arrive is as short as possible. Use that standby option. And let's see if we can't kind of move the needle a little bit about getting trauma patients to maybe a more appropriate, given that particular circumstance, than what we have in the past. So anything else?
No, I agree completely. These are rare events. But as things go in EMS, they all run in groups. Just like we had a little string of errors in terms of how we administer our infusion medications, now we've had a couple of really critical trauma cases back to back to back. That's how things go. I trust your care. You guys give phenomenal care. And that's in due to part to the extensive education program we have here, to the generous protocols we've given you to work under. And I know you guys make the right call. Trust your intuition. Trust your gestalt. A lot of that comes with experience, and you need to see things to have experience. But when your gut is telling you this patient is going to be pretty sick, I'm not going to second guess you. If you're going to activate a helicopter for that case and you have reason to be doing it, you have my back. And so those aren't ones where you're going to have to worry there's any repercussions or someone's going to be second guessing you. We're not looking to open Pandora's box and be using helicopters left and right, but we do believe there are cases that we can be capturing where we can be improving on these patients' care by getting them to definitive care. When I say definitive, patients that need a level 1 or 2 need a level 1 or 2 as opposed to a 3 or a 4. And we can get them there within that golden hour. So that's about all I have to say. Thank you.
If you've got any questions, you can always reach out to me or any of the chief officers. We've spoken, like I said, extensively about it. Look for the new policy. Talk as partners about circumstances that you think might fit that, maybe calls that you've been on in the past, or so that you kind of prime yourself for those instances. And like Mark said, I can't agree with him anymore. You guys are doing really good care. We hear about it a lot from our physician partners at both places. And I'm super proud of the work we're doing. You've heard me say it. We're a young department. We're gaining experience. We're gaining knowledge. We're doing really good things. And this is just another way that we hope to empower you to take the very best care of our patients that we can. So if you have any questions, reach out. Don't hesitate. You've even got Dr. O's email if you want to reach out to him about, I would say it's fair to say, about any topic.
Yeah.
And thanks. Appreciate the work you're doing.
Thank you all.